Karen Robom. I'm the behavioral science faculty at the Family Medicine Residency of Western Montana. It's my distinct pleasure to introduce Dan Knotts today. He's the medical director for Recovery Center Missoula. He's worked in a number of addiction programs. He's really helped to enhance the expertise in the Missoula area. And we've had the pleasure of having many of our residents work with him on an addiction medicine rotation. So again, it's my pleasure to introduce Dr. Knotts.
Thank you. The addition of the residency program is, I think, an incredible asset for our state. We have residents come through on an elective basis at this time, and I think most of those residents, it helps desensitize them around these problem areas around opioids, and this particularly benzodiazepines. In addition, we train APRNs and physician assistants and medical students. So I guess my belief is if we teach, it keeps us sharp, and we're hopefully doing something that'll change some of the problems we're talking about today. Some of the other things I do, I'm a consultant for the Montana Assistance Program, so that if you're a nurse or a pharmacist and you get in a problem with your board, you may end up talking with me at some point. Hopefully not. Then I recently became a member of the Drug Utilization Board of Mountain Pacific Quality Health, which is involved in assessing the appropriateness of certain drugs for our formulary, in particular to Medicaid patients. And that's been an incredibly rewarding experience for me. I'm learning a lot, as well as being able to provide input in particular regarding opioids and benzodiazepines. The other thing that isn't up there, I was the first buprenorphine provider in the state of Montana. I'm pretty sure I was. And so I have a fair amount of experience of that, and the second half of my talk is going to speak to some innovative strategies in utilizing buprenorphine in addressing patients with high-dose opioid dependence. William Osler is probably credited with the development of our principles of modern medicine. In fact, he edited a textbook, The Principles and Practice of Medicine, way back in the late 1800s or early 1900s. And much of what we've been talking about today and yesterday speaks to the problems in focusing only on a specific disease process without looking at the whole patient. In that we have a variety of disciplines represented here, it is an incredibly positive thing, and hopefully good doctors will work with all of you. In addition, he said that basically listen to your patient, because he or she will tell you what their diagnosis is. And that is unfortunately, in some respects, with the increasing technology in medicine, I think we tend to rely too much sometimes on our sophisticated diagnostic studies. And sadly, I think we get to a place where we no longer actually touch patients and examine patients. And it's reassuring to hear Dr. McCarthy speak regarding the osteopathic approach, because I think that is an incredibly healing process, that we actually touch patients, provide manipulative therapy, and so on. In addition, the alternative or complementary. This is a picture of silos I found, and you can put your label on those. So we can have neurosurgery, we can have primary care, we can have psychiatry, and so on. Unfortunately, when we get in silos, we don't particularly talk to each other. And guess what happens when we don't talk to each other? We get really confused. So it's safer to stay in those silos. We probably can make more money if we stay in those silos. We probably can spend less time with our patients if we stay in those silos. I think these are some of the process issues that we have to look at in addressing these multi-system problems. Then the other issue, and I think, I'm sure some of you in this room are aware that depending on your background, you don't necessarily have a high degree of comfort in working with patients with complex medical issues. So I think we have a responsibility to, excuse me, to interact with our counselors and so on, and hopefully we can work towards training each other. I really believe that most of the people that, we're preaching to the choir, in a sense, by the people that are here today. I think we all have an idea of what needs to happen with this population of patients, but education is not enough. I really feel strongly that political action is necessary. I've worked with the state at a variety of levels and in trying to improve care with with complex patients with substance use disorder and chronic pain issues, and they're all very understanding, but sadly nothing changes. So I think I'm hoping that out of this process with Dr. Mentel and some of the process going to occur later today, that we can have an action plan, perhaps to go all the way to the governor, frankly. It is my understanding he has an interest in addressing the opioid epidemic, and this is an opportunity to get him to a place of action. There was a comment earlier in the conference regarding the fifth vital sign. I think it was a good thing that we began assessing pain. What wasn't a good thing is it became a standard by which patients could take legal action against physicians. And what that led to was essentially a sensitization of physicians. They feared malpractice suits, even though it was happening infrequently, as one of the previous presenters stated. It still made physicians very vulnerable to a patient was, you're not adequately addressing my pain. So you need to give me what I need. So that, I think that's less at this point given the situation we're at this time. The New England Journal of Medicine, NEJM, in the early 90s provided in one of their publications that basically opioids were non-addicting in chronic pain. Unfortunately, that has not been proven to be true. So there's some of the other factors, I think, that have led to sort of the epidemic also is the influence of managed care and payer restrictions on substance abuse treatment or addiction services. And this began occurring in the 90s and through the 2000s. Fortunately, we are seeing, again, given the situation, that there's better support for treatment. The other issue that historically, if we look at when the last opioid epidemic was, it actually followed the methamphetamine epidemic in the 90s. Opioids epidemics tend to follow stimulant epidemics. And that's what we're facing. We went through a huge marketing strategy in attempting to address methamphetamine use disorders through a marketing campaign through the Montana Meth Project, which was very effective. Unfortunately, that sort of dwindled, and guess what's happening? Meth is back. It's not gone. This, unfortunately, is sadly humorous, and unfortunately, it happens a lot. Approach to treating non-malignant pain. Start with an NSAID. That doesn't work. Try some hydrocodone. That doesn't work, give something stronger. If it still hurts, give more. And if it gets worse, no matter what I do, discharge the patient, blame the patient, express your anger towards that patient. So in a sense, we become part of that patient's trauma. I'm sure you've all seen patients that indeed have ended up in your practice because of what happened to them and when they were discharged from their physician. So, you know, there are clearly educational and training deficits, especially amongst physicians. And, you know, I think locally we're addressing those, and that's a really good thing. But some of the issues that are much more difficult to address are issues of time and money. These are complex patients. They take a lot of time. Dr. Miller spoke to taking 3 sessions before he even made a decision whether or not to prescribe or not. Well, in a private practice, that would be somewhat difficult to do. And then there's the money issue. You might need to spend a lot of time with this type of patient. Is the insurance company or the managed care company going to reimburse you for that time? Probably not. They're probably going to reimburse you for one problem. So it's pretty difficult to follow Osler's dictum. The other issue is one of stigma. And you remember that many, you know, I think there's a preconceived notion that most people that seem to get into trouble with this class of substances are sort of down and out from the beginning. Not true. This has become a problem that cuts across all socioeconomic classes. But we can see a downward spiral. Someone who started off as being middle class may end up in a state of poverty because of the subsequent use of opioids and other substances. A simple screening tool, and you know, I support what Dr. Miller presented, but a very simple tool that has a high level of sensitivity and specificity is the following question. How many times in the past year have you used an illegal drug or used a prescription medication for a non-medical reason? One's a positive, you know, so positive. So if the answer, yeah, I have, or used once, that's a positive. So we're talking about 100% sensitivity and a 78% specificity. That's better, frankly, than most laboratory tests we do in the practice of medicine. So, you know, if that's a great tool. I think we really sometimes have to really support our primary care doctors. I think, you know, they're confused, they're fearful, they feel abandoned and angry for caring for patients with chronic pain, as well as substance use disorders, plus psychiatric issues. You know, they're almost always together. It's, you know, there's rarely anything that's pure anymore. And they also, you know, they feel that they're going to be judged, in a sense, when they prescribe controlled substances. And then you've got management, you've got people that are worried about your productivity, you've got regulatory agencies, and the media. NPR, not long ago, basically accused doctors that were providing medication-assisted treatment for patients with opioid use disorder as being legitimate drug dealers. This is not helpful. So again, our primary care providers deserve our compassion and support in this population. This is a typical patient. They've experienced trauma. So part of that initial assessment that Dr. Miller was speaking to needs to speak to, and it may not be able to occur in the first visit. You can't necessarily jump into doing a trauma assessment the first time you see someone. But you've got to get it, because that is probably one of the most relevant risk factors that you're going to define. Is there a mood or anxiety disorder? Is there a history of a substance use disorder? Or is there a current substance use disorder? What types of screening are you doing? And it comes back again to doing universal screening, whether it's an admission to a hospital or admission to your primary care clinic. If you look at primary care practices, 20% across the nation of your patients have a substance use disorder. So you can't say it's just you're just a primary care clinic, because you're addressing you're seeing those patients, they have a problem, and you are the most effective person to essentially help them define their problem and try to motivate them to a place of doing something about it. Then we have the chronic pain and other medical issues. I mean, it's the patients, of course, I'm seeing a subset of this population. They're patients with substance use disorders, usually a mood disorder, an anxiety disorder, a personality disorder, and a chronic pain diagnosis. I recently just admitted a young woman who's very middle class. She'd had a multiple of GYN problems, multiple history of surgeries. I asked her, and basically this person has an opioid use disorder. I asked her, how long was it that before you started realizing that you were using the opioids for a lot of other things than to manage your pain? And she said, yeah, I found out I just felt better, I could get things done, I could get through the stress of the day better, et cetera, et cetera. That was 3 months. So that's about the point at which the CDC guideline has defined what chronic pain is, greater than 3 months. The other things are genetics. People respond differently to substances. Bill W., I'm sure you all know, is one of the co-founders of Alcoholics Anonymous. And basically he said when he had his first drink was, alcohol dissolved the invisible barrier between myself and the rest of the world. Well, I have patients that say the same thing about opioids, that they have been able to become more social, comfortable, etc. And one of the other presenters spoke to the fact that opioids are fairly effective anxiolytics. And not a well-known fact is that opioids actually are effective antipsychotics. They've not been utilized in this country for that, but in Europe, actually, they have. The genetics is yet to be defined, but we know that there's a subset of our population that seems to be more at risk. The bottom line, the proof's in the pudding. If we prescribe to 100 people, there are probably only going to be about 7 to 10 of them that are actually going to develop problematic behaviors with their opioid use. This is a gene, the OPRM1. Don't ask me what the letters mean, but it encodes for the target of opioids. And then there's a variant, and having that variant, it affects the opioid receptors in the brain, and it's associated with increased risk for development of addictive behaviors as well as overdose. So I think this is an area that hopefully we can expand upon in the future so that we have better screening tools, at least from a laboratory standpoint. And this, I think, I put this in here because I think it's so important from the standpoint of trauma. Trauma is such an important part of substance use disorder treatment. If you have a person with significant trauma, and that's 70 to 80% of our patients, if you don't address it, their outcomes are very poor. And I think the same thing applies to problems with chronic pain. In a sense, I think with Dr. Davis, I think with the plasticity of the brain, trauma affects our brain. It may shrink our brain, or gray matter. And I'm hoping that by doing appropriate therapy, cognitive behavioral therapy, dialectical behavioral therapy, et cetera, that we can help those brains recover. But Jung, I don't know if you're all aware, was a psychoanalyst in Freud's time, and he's responsible for defining archetypes. But he also had a role in the development of Alcoholics Anonymous. He referred a patient to Bill W., basically saying, I've done everything I can. I've looked into this person's history. I feel like I have nothing left to offer him. I'm referring to you, hoping for a spiritual awakening. And that person did go on to establish some recovery. I've touched on most of these items. I'm not going to go through that. It'll take too much time. This, you're going to wonder, why am I bringing this up? It's a study that was recently reported in the Green Journal, American Journal of Medicine. It's looking at 102 patients with endocarditis, acute infections of the heart valves, mostly Staphylococcus aureus, incredibly destructive bacteria. The mortality in this group was 25%, most of them dying within a year of their diagnosis. They were younger people, 20 to 49. 50% of them got readmitted to the hospital. Now, how do you get infectious endocarditis? You get it from IV drug use primarily. You can have abnormal valves from rheumatic heart disease, but that's pretty rare anymore. So the primary culprit is IV substance use. These patients are incredibly expensive. This happens in Missoula, Montana. We treat patients that are post-op and post-treatment for endocarditis. Their hospitalizations run usually around $500,000. This is the sad part, and this is why I'm bringing this up. 85% saw a social worker while they were in the hospital. Well, what do social workers do in the hospital? They really don't do psychosocial assessments. They do discharge planning. So that's not much. 23% saw an addiction clinical nurse. Well, that's pretty good. I've worked with addiction nurses that have been just absolutely phenomenal. But where's the consultation with the addictionist or the psychiatrist with an added qualification in addiction medicine or addiction psychiatry? Now, we don't have many of those people, I admit that. But this was a study that was, these patients were in urban and suburban areas where there was access to many of these types of professionals. 24% had a psych consult. How well do psychiatrists understand substance use disorders? Not particularly well, unless they have a particular interest or had specialized training in their program. The Mayo Clinic, for example, all the residents rotate through an addiction medicine, addiction psychiatry service. That is the exception rather than the rule. So I think we're at the forefront here with the Montana residency program, in that doctors actually have a rotation available to them. Now, addiction was mentioned in only little more than half of the discharge summaries. 7.8% had a plan for medication-assisted treatment. Well, that's a separate workshop, but in opioid use disorder, the most effective treatment is medication-assisted treatment with either buprenorphine, methadone, or naltrexone. It increased with the readmission to 18%. Wow. And with surgery, to replace their valve, it decreased to 6.8%. It got worse, but they still didn't refer the patient for care. There's this distorted belief system that if a patient goes through such an incredible illness and possible surgery, they somehow understand they should never do that again. That doesn't work. That's not treatment. Years ago at my alma mater, they did a study taking DUI people that had been convicted of driving under the influence, took them out to horrible accident sites so they could see what happened to people driving under the influence. They were all appalled by what they saw. However, it did not change their relapse rates or recidivism rates whatsoever. Naloxone was never prescribed. Naloxone rescue is saving lives in our country. In Baltimore, Maryland, with naloxone, providing it either by injection, an EpiPen type of tool, or with an aerosolizer, it's dropped their death rate by 37%. So part of this is if we're in the business of prescribing opioids to patients with chronic pain, we need to counsel them around the potential for overdose, and that families are aware, and that these kits are available. On a case-by-case basis, Medicaid will cover for naloxone. Anyway, what happened there with that case in the hospital, or those cases with the endocarditis, is the problem was clearly identified, but it wasn't addressed. That is a real deal breaker for JCAHO. And I think, on bottom line, those of you who have hospital privileges and are active in your hospital staffs, this is a risk management issue. And I think the lady from UMIA, I think we're pretty good at putting pressure on docs, other prescribers. We're not very good at necessarily changing hospital behavior, because they're part of the problem too. Let's talk a little bit about DSM-5 and the diagnostic criteria for opioid use disorder, because I think, unfortunately, it gets a little hard, especially when if the person doing the assessment isn't particularly aware of the medical issues and the pain issues the patient's dealing with, that it's very easy to overdiagnose a substance use disorder in this population. First of all, they're going to have tolerance. Second of all, if you stop the opioid, they're going to have withdrawal. That's 2 of the 11 criteria that are met right there. However, with DSM-5, they had said they've dropped those 2 criteria because basically they're saying if their opioid use is under medical surveillance, those don't count. A licensed addiction counselor may or may not be aware of that. You can interpret opioids are often taken in larger amounts over a longer period than was intended. Well, many of our patients don't want to take more, but they get to a place where they feel they need more. That could be applied. There's a persistent desire, unsuccessful efforts to cut down or control use. Many of our patients don't like being on these medications, and they'd like to get off if they're not doing well. A great deal of time is spent in activities necessary to obtain the opioid. Well, if they've been fired by a doctor, they're going to spend a lot of time. You could interpret that as potentially reflecting addictive behavior. So it takes, I think, where this goes is having a more functional definition, and I prefer the American Society of Addiction Medicine definition. Essentially, that addiction is characterized, and again, addiction, let me back up. The DSM-5 basically is trying to destigmatize these illnesses by getting away from calling it addiction or calling it dependence and calling it substance use disorders. They dropped the designation abuse. The abuse diagnosis no longer exists. The scoring is basically based on how many of the criteria are met. So ASAM basically says inability to consistently abstain, impairment in behavioral control. That's a biggie. Craving. And these are questions you can actually ask your patients who are being managed for chronic pain. Are you craving the opioids? Are you using them for other things than your pain management or improving your physical functioning? Diminished recognition of significant problems and in interpersonal relationships, and a dysfunctional response. An easy acronym that speaks to this definition is inability to abstain, A, impairment in behavioral control, B, craving or increased hunger, C, diminished recognition of significant problems, and lastly, a dysfunctional emotional response. So those are, what can we do? I mean, we've all been faced by, and I'm faced frequently, State Fund called up one time and said, gosh, we've got a patient that's on 600 morphine equivalents. Can you detox this patient for us? Oh yeah, we'll get right on it. That's a challenge. It takes a long time. It's very difficult to do as an outpatient. Most of our hospitals and our hospitalists aren't interested in doing it. And if it's methadone, it's even more difficult because of the incredibly protracted withdrawal. This work is as the last time I checked, is still unpublished. Herbert Malinoff is head of a pain program at the University of Michigan at one of the affiliated hospitals at St. Joseph's in Ypsilanti, Michigan. And he and his colleagues there have developed some protocols in addressing people that are on very high levels of opioids. And, you know, in his population, he's, you know, seeing people that have opioid-induced hyperalgesia. I think most of you are aware that if you're on opioids a long time, that your tolerance for pain goes down. And you know, you can measure this by how long you can tolerate your hand stuck in a bowl of water with ice, and so on. And this is a patient population who, despite being on high doses of opioids, may well admit that, hey, my pain's, I still have terrible pain, and I don't think that medicine works anymore. And also, the families often are complaining. My husband's just not there. He's nodding off all the time. Okay, I'd like my husband back, or my wife, whatever. And then, so let's look at what they've developed. And I'm praying that someone in this audience will possibly do this. I no longer practice in the hospitals, so this is a protocol that needs hospitalization. This is a typical patient. It's a 50-year-old woman with myelodysplasia. She's had a bone marrow transplant. She's had a lot of osteoporosis, osteopenia, and has compression fractures, and she's diagnosed as having neuropathic and myofascial pain. She's wheelchair-bound, has lung disease, O2 dependent, smokes 1 to 2 packs per day, and she's on 32 different medications. These are all her pain meds and sedative hypnotics. Fentanyl, OxyContin, oxycodone, alprazolam, Xanax, cyclobenzaprine, Flexeril, muscle relaxant, zolpidem, Ambien, sedative hypnotic that's used for insomnia. She rated her pain at 10 over 10, despite all the opioids. Dr. Nealon say, hey, that sounds like one of my patients. History of cannabis use, though she quit a year ago because she felt it dumbed her out even more. No substance use disorder history. She had depression, anxiety, insomnia. She couldn't remember. Guess what the current recommendations of the FDA on zolpidem or Ambien is for women? It's 5 milligrams, not 10 milligrams. And the reason? Amnesia, memory difficulties. Attempts at quitting. She's tried to quit. That's a good sign, actually, when patients say, yeah, I tried to quit. I tried to cut down, but I can't. I get so sick. She got depressed. She vomited. She had diarrhea. She got dehydrated. So Dr. Davis went into the neuroplasticity. PTSD, not only from their developmental history, is common, but also from their experience with us, the providers. Substance use disorder associated. You know, the alcohol is an issue as a sedative hypnotic. Remember that alcohol is a general anesthetic. You know, patients will use alcohol to try to affect their pain. Well, doc, I drink so much because it's the only thing I can do to take care of my pain. So why use opioids to begin with? I think the key element that we've learned over and over in this conference is that the pain almost is, relief of pain is secondary. Improving function should be primary. And one of the strategies I've heard in several settings was basically have the patient themselves define 10 things they want to be able to do that they haven't been able to do. Delete those that aren't measurable, and that's how you do your documentation as far as following function. So why stop opioids if they're not working? I mean, that's like any other medication. If an antihypertensive is not effective, we get rid of it and try something else. It's not, you know, it's getting back to the sort of the pharmacologic and mechanistic thinking that many Americans demonstrate. You know, if I've got a problem with my knee, I need surgery. If I have a problem with pain, medication should fix it. So it's broadening the patient's awareness of all these strategies that we've been discussing to manage their pain. So like this lady, she was functionally deteriorating. She wasn't getting better. So what can we do? Well, you bring up, you have to, this protocol basically requires hospitalization because it requires monitoring, it requires telemetry, it requires, especially in a person with chronic lung disease, they're going to need 24/7 O2 sats, and so on. See, and you need the nursing observation. So you want to be able to monitor the cardiac status, the respiratory status, and be able to frequently do withdrawal assessments. Now, one of the points I made earlier, we've kind of lost the ability to touch patients. Oh my gosh, 2 minutes. And assessing patients frequently decreases their requirements for medication. This has been demonstrated in multiple withdrawal protocols. So this group, okay, his study group, they were 58 males, 47 females, average age 54, employed only 22. Medical problems, 93 out of 105. Psych problems, 92 over 105. Substance use, 2/3 of them. Failed back, fibromyalgia. And actually, I want to make a point about Dr. Schneider. I really, you know, I know she was somewhat critical CDC guidelines. Fibromyalgia, the Mayo Clinic in their proceedings in the last couple weeks basically published a review of treatment for fibromyalgia. There is no evidence that opioids have any efficacy in this problem. None. I cannot, so we need to use that. We do not need to get into the trap of prescribing to patients with fibromyalgia. Abdominal pain, headache, pelvic pain, 21%, other musculoskeletal pain, and so on. Pretty typical stuff. The average morphine equivalent's 430 milligrams per day. Sedative hypnotic use, benzos, the Z drugs like zolpidem, muscle relaxers. Muscle relaxers. Do muscle relaxers work? There's a study that's probably 20, 25 years old that was done. Excellent, double-blind, randomized, controlled studies. Maybe some benefit for 48 to 78 hours or 72 hours following an acute back injury. Otherwise, there's no evidence for chronic benefits, and you're just adding to the sedative hypnotic load in this patient. So, the methods, I'm going to go over time. It's basically this protocol utilizes buprenorphine. Part of the reason I want to do this is because I want more people that have waivers to prescribe buprenorphine. I've succeeded, actually, in the last 12 years in converting 3 physicians to a place of where they were willing to get their waiver to prescribe this. You need to do an 8-hour course, apply to the DEA, then you can prescribe the medication. The requirements are that you make sure the patient is engaged in treatment, though they don't define that, at least counseling, but definitely more than just 12-step mutual self-help. Buprenorphine is a partial agonist at the mu receptor. It has low intrinsic activity, but it really strongly binds to the mu receptor. It doesn't, if you overdose with buprenorphine, more than likely what's going to happen to you, you're actually going to go into withdrawal rather than become overly sedated. It's an antagonist at the kappa receptor, and that's probably why, in a sense, with the higher doses, and essentially you start going into withdrawal. Phenobarbital for the sedative hypnotics, low abuse potential, and very effective. Little euphoria. The diagnosis they used for this population was intractable pain and medication toxicity. Essentially what they do is bring the patient in, start them on a patient-controlled analgesia pump with dihydromorphone or Dilaudid, let them stabilize on the Dilaudid for several days, usually 2 to 3 half-lives of whatever they've been using, and then stop the PCA. Let the person drift into withdrawal, not severe withdrawal, at least mild to moderate withdrawal, and then begin buprenorphine induction. Usually it's started at a very low dose. You try to get to, you try to use as low a dose as possible to get the patient comfortable and without withdrawal. The average hospitalization was about 7 days. Methadone is more difficult because of its long half-life. And essentially you have to monitor the methadone blood levels, and you essentially stop the PCA when the methadone level drops below 30 nanograms. Otherwise, then it's the same protocol. So what were the results? The average median buprenorphine dose at discharge was 8 milligrams a day. Many of you probably don't know what the morphine equivalent of buprenorphine is. 1 milligram is equivalent to 10 morphine equivalents. So that's 80 morphine equivalents when our patient was at 430. Median phenobarb, that's for dealing with the benzos and the muscle relaxants, 60 milligrams. Essentially, 30 milligrams of phenobarbital is equivalent to 10 milligrams of diazepam. Follow-up in 7 to 10 days. No deaths, 69% improved function, and reduced pain. Imagine that, reduced pain with 1/4 the amount of opioid equivalent. What was noted was improved cognition, sleep, functional ability, and so on. Now, so at 14 months, pain control was improved again, 69%. Function improved at 64%. Those are phenomenal results. So the patient that we described, her pain scores went down, mood and memory improved, husband and patient happier, remains in wheelchair but O2 dependent, and she's still smoking. But no sedative hypnotics or pure opioid agonists for 9 months post-treatment. Okay. This is a separate issue. I won't go into it because we've run out of time. But simply put, conversion of people to low-dose buprenorphine may allow you to prescribe other immediate-release opioids without addictive behavior when it previously was there. There's something about buprenorphine that resets tolerance. Okay? Then one more comment is the CDC guidelines. I've been involved in the development of 2 practice guidelines in my career, and I don't know how many of you've done that. It's an incredibly exhausting process. You put together a group of so-called experts, you review usually the English literature, you look for double-blind, randomized, controlled trials, and sometimes they just don't exist. And so sometimes you have to sort of go by consensus. And I think that's what the CDC guidelines are. I don't think it's the be-all, end-all, but it's a start. And I think the increased awareness of how we prescribe for acute pain and the awareness of the risk of using sedative hypnotics, in particular benzodiazepines, is incredibly relevant. I'm hoping that it doesn't get taken in the same way the 5th vital sign was, that if we don't follow these guidelines strictly, that you're going to get sued. I hope not. I'll stop at that point, and thank you very much. And how much time do we have for questions?
We have enough time for maybe 2 or 3 burning questions.
Okay, very good.
Hi, I'm a member of a nonprofit insurance company called Montana Health Co-op, and I have a hunch that the board members would be amenable to having someone come to the board meeting for education on pain management. Because you want the insurance companies to reimburse you, right?
Absolutely.
And what I'm suggesting is, I think that it's a really progressive company, and I think, but they need to be educated about pain management.
Right.
Is my suggestion to you for political stuff.
Yep, I agree. I'd love to do that, but I'd want to do it with one of my colleagues whose
Sure.
primary focus is pain. My
Right.
primary focus is their substance use disorder, but we do address their pain in that context. The other thing is, obviously, there's a subset of patients who we treat in our substance use disorder treatment program who have been maintained for years on a stable dose of opioids and have been functional, who we do not we do not remove them from those opioids. There's no addictive behavior associated with those opioids.
Right.
So, and a lot of people are afraid, well, if I come in there, are you going to take my medication away? No, we're not. So that's, but no, I'd appreciate that opportunity,
Okay.
yeah.
So how do you feel about the buprenorphine patch?
I think it's an excellent alternative, especially in an individual that has a risk history, like Dr. Miller suggested, as well as, that's complex with all those overlapping circles. That may be the first. The thing is, I think I still have a bit of a problem with the moving to a patch without demonstrating that there's a benefit from a short-acting preparation. There is a buccal preparation now, Belbuca, I think it's Belbuca, of buprenorphine that you don't need a waiver to prescribe. Now, buprenorphine in the usual, there's several preparations on. There's generic buprenorphine, naloxone. There's Suboxone. There's Subsolve. There's Bunavail. They're all essentially buprenorphine, naloxone combinations. The naloxone is a deterrent for IV use with the buprenorphine. Buprenorphine is not perfect. There's a lot of criticism of medication-assisted treatment out there, and I think it's generally naive and uninformed, and that is that essentially we're just continuing their addiction. The brain is altered after 3 years, at least at some point around 3 years with regular opioid use, at least in an addictive manner. An abstinence model for that population is effective 7% of the time. Well, that's right in there with the natural remission rate of patients using heroin. If you follow a lot of heroin addicts, about 7% of them are able to stop on their own. So an abstinence model of treatment is not effective in the chronic opioid use disorder patient. So we have 3 options: methadone, buprenorphine, and naltrexone. So yes, I think it's an option, but I would probably, before going there, and they haven't been around very long, I would probably make sure the person had some benefits from something like the buccal form. Now, before Congress, actually this is one of the things that both the Republicans and the Democrats agree on, that we have to do something about the opioid epidemic. So as it is now, if you get your waiver, in the first year you can only prescribe to 30 patients, despite the fact that you can prescribe unlimited amounts of oxycodone, hydrocodone, morphine, whatever. Okay. So they've restricted the tool that helps people. After a year of experience, you can apply to have 100 patients. Well, unfortunately, guess what? Not all of our doctors are terrified of working with this population, despite the fact you're working with them every day anyway because they're your so-called problem patients. So I say, why not develop the tools to address the problem in your practice? And these patients then become actually good patients and really very appropriate and very responsive, very compliant. So anyway, the new law will increase the number of people that a person with a waiver can carry, possibly up to 500 patients. In addition, it'll be broadened to allow nurse practitioners and physician's assistants to get their waivers, which I think is an incredible thing. So I'm all for it.
Okay, so unfortunately, we're out of time for any
okay.
more questions. but we'll move on to the next speaker.
I'm just going to make one more comment. I'm proud to realize I'm only one of the 3 people that Dr. Knott's convinced to get his X license. So you need to get better at persuasion. If I'm the I'm only going to build on what Dr. Knotts was talking about is in residency when I was being trained, and for those who haven't gone through medical residency, usually there was a saying, you see one, you do one, you teach one. In our residency, we had a saying, you see one, you do one, you teach one, you screw one. It's not until you mess up in your treatment plan and learn how to fix it do you really understand what you were treating in the first place. So I would make an impassioned plea for those of you that are going to be practicing pain management to also learn how to treat your patients once they may get into problems. The best place for that to happen is in the primary care with the person who prescribed it in the first place. I can't make a plea any more than that. So if anyone wants to talk to me about the process of getting the X license, it's not that hard, but I'd be happy to share that after. Our next speaker we're going to bring up, just to let you know, we are running about 15 minutes behind, but I know the person who's in charge of most of this afternoon, and I have a feeling we can shorten that, and I still believe we probably can get you out of here about an hour to an hour and a half early, even with lunch and everything built in, so I hope people are happy about that. So I'll bring our next speaker.
Great. I'm going to go ahead and introduce our next speaker. My name is Kristen Page Nye, and I am here representing the American Cancer Society Cancer Action Network. And the Cancer Action Network and the American Cancer Society, its affiliate, are very excited to be here today, but also are really proud of the work of the Montana Pain Initiative. We've had the opportunity to be a part of it since its inception. And as our next speaker has, I'm introducing Dr. Catherine Borgenicht, and she has been a part of the Montana Pain Initiative since its inception too. She was on the very first conference planning committee. She's a board-certified geriatrician and palliative care physician, She's the medical director for palliative care consultants at Bozeman Health, medical director of hospice of Bozeman Health, and is currently the co-chair of the Montana Palliative Care Initiative. Please welcome Catherine.
Can people hear me? Yeah? Okay, great. Okay, so thank you, Kristen. You have been a great partner in all of this. And I apologize for not having been here yesterday, but I was doing a little bit of mindfulness and going camping with my husband, who I hadn't seen in a couple of weeks. So I apologize. And some of what I say, I think you will have already heard. But hopefully it will give you a little bit of more perspective on this issue. So first of all, what is palliative care? How many of you have exposure to palliative care, know what it is, have worked with palliative care docs? That's great. There's a lot of confusion about what palliative care is. I think the last line, living maximally in the face of serious illness, is probably the best, shortest definition I've ever heard. But the definition that you'll go online and find from the Center for Advancement of Palliative Care, from a lot of other sources, is for people with serious illness and their family, which provides relief from pain and other symptoms and supports the best quality of life for the longest possible time. Just so you know, it says nothing about dying. It says nothing about not healing. It says nothing about stopping treatment. Palliative care is done at the same time as people are getting a lot of aggressive treatment. So just wanted to clarify that. Not just for people who are dying. It's not hospice. Hospice actually is sort of the ultimate in palliative care. I see palliative care is up here, and underneath it are a variety of different things. We're in the cancer center once a week at Bozeman Health and doing palliative care there. We have a huge palliative care inpatient program. Of those patients who are seen in inpatient, only about 30% of them actually end up going to hospice. It's not chronic pain management, and I'll talk about that a little bit. It is good pain management, and can and maybe should begin at the start of a serious illness and done alongside treatments designed to combat a patient's disease. Those of us who are palliative care docs think that palliative care should actually start almost at the very beginning when anybody gets diagnosed with a serious illness. But actually, I look at it also as really good patient-centered care. Okay. Multiple studies about the benefits of palliative care. Better quality of life, better symptom management, longer life, which is really interesting, better patient and family satisfaction. The thing we don't like to talk about that much out in the public is that it actually maximizes hospital efficiency and lowers cost. When we talk to CEOs, that's really important. The prevalence of palliative care programs has just mushroomed. Okay, so it's increased over the past 11 years, 157% in hospitals that have 50 beds or more. 96% of doctors support palliative care, although they're not always sure how to use us. Okay, so that's a big education process that we're constantly doing. Once informed about what palliative care is, and that we're not death panels, we're not the death doctors, we're not Kevorkian, all those other things that came along with some of the baggage from the Affordable Care Act, 92% of consumers said these services should be available for seriously ill patients and their families. At Bozeman Health, our inpatient service in an 80-bed hospital sees over 600 palliative care inpatient consults a year, which is huge in that size hospital. And we are sought out by patients, nurses, both in the ICU and on the medical floor, in the emergency room. So we've become extraordinarily important for these people. I want to talk briefly about the Institute on Medicine report that came out in 2014. And basically it was called How We Die, which is also a terrible name for it, but it was an anonymous donor who asked that we do it. And so he or she, I have no idea what sex this person was, said, okay, I want you to do this report, but you have to call it How We Die. And those of us who are in palliative care who struggle so hard and educate so long about how palliative care is not about dying, then this comes along and we're like, oh, okay. Anyway, so it was to evaluate the current state of end-of-life care with respect to delivery, communication, advanced care planning, financing, costs, and education of professionals, patients, and loved ones. And it came out basically saying, reiterating a report that came out in 1996 that said we're still dying not so great in this country. Not only that, we're still not controlling some symptoms when you are seriously ill. They came out with 5 recommendations, and I'm not going to go into them in great detail, but they basically is everything that we do as palliative care. So first of all, they said delivery of care, cover palliative care in all settings. Well, that's easier said than done. We can do it pretty well in the inpatient setting. In the outpatient setting, because so much of what we do as internists, geriatricians, palliative care docs is based on RVUs, productivity basically, becomes a little harder in the outpatient setting to say, well, we're going to go out and see this patient in their home for 2 hours and then come back and document for another half hour. And how does that correlate in terms of our productivity? So we're looking at that. The growth of outpatient palliative care is happening. It's just a lot harder to quantify than what we do on the inpatient setting. Deliver standards for communication and advanced care planning tied to credentialing and reimbursement. So we have a procedure in palliative care. You may not know that, but we do, and it's called Goals of Care, Advanced Care Planning, Serious Illness Conversation. I spend most of my time, a lot of my time, starting out my conversations with patients about what matters to you, what's important. Okay, so we need to, and I'll show you why, we need to be training other providers, not only in pain management, and I'll talk about that in a minute, but also on how to have these conversations, because they guide almost everything I do with my patients. We now have an array of reimbursing for advanced care planning. Medicare, CMS has actually said we will pay you for this, but the actual doing of it is much harder. For example, in our hospital, we have just switched over to Epic. Some of you know Epic. the electronic medical record. Well, there are a couple of issues around EPIC and advanced care planning, one of which is if you do an advanced care planning note, which is not well lined out at this point yet in our system because we're just beginning it, you also have to do another note, and you can't do both notes at the same time. So in terms of documentation, it actually has created a large burden for our providers. So it's not that easy to use this increased reimbursement, which ends up not being that much anyway. Professional education development for palliative care. There's a bill out there called PACHETA. That's actually the American Academy of Hospice and Palliative Medicine has been tracking this bill for only, I think, 8 years. We hope to get it through Congress at some point, which would increase money to train docs around palliative care and indeed in some pain management. Integrate financial delivery of medical and social services. So one of our biggest issues when we're dealing with palliative care, and there's been lots written about this, Atul Gawande has some wonderful stuff about part of the issue with taking care of seriously ill patients is that they don't have the social support that they really need within the community to keep them out of your office, to keep them from running into trouble with chronic pain, to keep them from getting good care with their serious illness. It's really not, I actually am a small piece of taking care of people with serious illness. I need the rest of the other people that I work with, both the nurses, the social work, the home health, hospice, and getting that coordinated, it can be very difficult. And then finally, public education and engagement. What we know about advanced care planning and looking at issues around goals of care and serious illness is that if the patients come to us and ask us about it, it's much better than if the doctor asks the patient. So docs are not that good about asking about advanced directives, okay? But patients, if they come to the doc and ask about it, then they get a little bit better at it. Okay, so the provision of early palliative care, we know that with a strong emphasis on communication and patient and family education, particularly in seriously ill cancer patients. We know we've had some great studies about it. It improves quality of life, less use of aggressive care. There's a 25% increase in survival. If this were a drug, I would be making a lot more money than I make as a palliative care doc, let me tell you. One of my colleagues calls it palliastatin. It would be terrific. And it's not about dying, it's about living with this serious illness. Okay, power shortage. Okay, we've got a big power shortage. Across the country, there are 4,500 palliative medicine docs certified. Okay, there are probably other docs out there who are doing palliative medicine, but only 4,500 of us have actually taken the boards and are certified. That translates to 1 for every 20,000 adults with serious illness. Okay. That's why we need to be training all of us in some of the basics of palliative medicine. There are 4,000 pain specialists. Okay. It's estimated that there are 116 million patients out there with pain. Now, we've heard a lot about persistent pain and patients who may not need the opioids, but I can tell you that's one of the main reasons that people come see you as a physician is because of their pain. Okay? If we were to follow some of the guidelines out there about seeing pain specialists would have a total of 14 minutes per patient per year. Well, we just heard earlier about how much time it takes to deal with these patients who have persistent pain. That's not going to work if we have to go to a pain specialist. Okay. So we can't provide this care to all patients with serious illness. We can't provide for all those patients with pain, so we need to have interventions that are targeted at generalist physicians, and that's some of what you heard today, and other clinicians to assure universal access. This is much easier said than done. I have been working, and I'll tell you in a couple of slides about my own personal history. But I have been working since the beginning of the pain initiative. Every time after these pain conferences, I go back home, go back to Bozeman and say, okay, what can we do? Okay. And we always have like 2 or 3 meetings, and then it sort of fizzles out because we're busy, we don't have the resources, we're based on productivity. I always am jealous whenever I come to Missoula because you guys actually have a lot of resources here. We have less resources in Bozeman, and they're not as coordinated for a variety of reasons. Part of it is actually finding the time to get it coordinated, and then having the providers actually be reimbursed for some of this really, really difficult work. I want to show you a couple of palliative care patients and where we have failed and where we haven't failed. This was actually a patient who should have been a no-brainer and was one of my patients, and I should have been able to forestall this, but I couldn't. And this is again, this patient was a 95-year-old man with congestive heart failure. He'd been on hospice for a year. He fell, okay? So he's got to go to the ER because he's bleeding so much. We've got to get him to the ER, get it stitched up. We don't have the ability among our nurses to stitch him up. Throughout his hospice stay, we've been very, very clear. He never wanted to go to the hospital except in these kind of situations, and he had a very clear pulse, okay? He went to the ER, and not only was a hospice nurse with him, but the social worker from hospice was with him, okay? And they had a copy of his pulse. The ER doc told him, he was very hard of hearing, so the ER doc was standing at the bedside yelling at him because he could barely hear her, saying that he didn't have to still honor his pulsed wishes, and that if he did honor his pulsed wishes, he was going to die in 2 weeks if he didn't get IV hydration and a feeding tube. The ER doc wanted to do multiple studies and evaluations. That's not good palliative care, and that was within my own system. Okay? So that's just an example of what can go wrong. He ended up going home. He got his stitches and went home and was petrified because his doc had said he was going to die in 2 weeks. He ended up living a couple more months and at home where he wanted to be. This is another palliative care patient that I have been following. I'd been following this patient for about a year. He lived with an unusual thyroid cancer for 10 years. Recent scans were negative, but he was getting increased pain and anxiety. I was consulted for pain management. He continued with his experimental chemotherapy for another year and had ongoing consultation with me as a palliative care doc and pain management. Finally, a month before he died, he went on hospice, and we were able to actually get him comfortable. But it was a big issue because not only was he in pain, but he was so anxious. He used to talk to me about how he thought he was going to suffocate from his cancer. So we had to deal with both of those. Ultimately, we ended up getting him comfortable, and he died peacefully. And this is the last palliative care patient I'm going to talk about. These are 2 people, a 90 and 92-year-old man and woman. The husband had dementia and sensory impairment. The wife had stage 3 congestive heart failure and severe peripheral edema. The note from the doc, who's one of my colleagues and a very good doc. This guy is a very good doc, okay? The 90-year-old woman came in, and his entire note, and this is one of the problems with EHR, was all about prevention, okay? In this 90-year-old woman, she doesn't need a colonoscopy, maybe she doesn't need a mammogram, she doesn't need this, she doesn't need that, and it did not address any of the issues that really needed to be addressed, which were, she needed to be visited at home. When I went at home, her husband can't see, has dementia, can't hear, spends most of his time in a chair, is a big fall risk. She spends most of her time in a chair because of her peripheral edema, and really what they needed was a hospital bed plus a lift chair. In addition, there was nothing in the chart when she came to the office about what they wanted in terms of their goals. And they were really clear with me. And the daughter was there, and they said, where is that form that says do not attempt resuscitation? They thought they already had the form, which they did not. So we were able to do that also. There's no easy way I can tell you this, so I'm sending you to someone who can. Okay. One of my favorite, this is a standard palliative care cartoon, let me tell you. There's not a single palliative care doctor out there that does not use this cartoon. I'm right there in the room, and no one ever acknowledges me. That's why I get the New Yorker, so I can get these cartoons. I rarely read any of the articles, but I want to talk a little bit about my own personal journey, because I think what we do personally influences who we are and how we take care of our patients. And I think it behooves all of you who take care of patients to look at that and pay attention to that. So I'm part of the fifth vital sign. In 1990, I was working at the VA, and there was a huge initiative to get the fifth vital sign going. And we saw it then as a tool, not a perfect tool, and it has proved to be a less than perfect tool, but it was really important because it was the first time that pain was actually acknowledged as being a problem. Okay, so yes, there's been a lot of reasons why it's not so great and how we probably ended up doing a little bit too much in prescribing, but it was the first time in my professional career that we were actually validating that people had pain and that it was subjective and we could not, I mean, I still have doctors who say to me, that person is not in pain because they're sitting there and they're perfectly fine. They look fine. They don't have high blood pressure. They don't have, they're not tachycardic. They're not sweating. They're not showing any of the signs that we might think of a person who has pain has. Okay? How many of you have had pain? Yeah. And does your blood pressure go up? Do you get really anxious? Or do you just, it's just part of where you're heading or what's going on with you at that point. So it is subjective, and I think that was really actually important for us to recognize. My sister is my sister, and that can say a lot, but she's actually a chronic pain patient. She's had pain for over 30 years. And through this conference, actually, I don't know how many years ago, 3 or 4 years ago, Dr. Moskowitz came and spoke about neuroplasticity, and I know you had a lecture about neuroplasticity yesterday, which sounded wonderful. And so I told my sister, she lives part of the time in San Francisco, I told her about Moskowitz, and she actually ended up getting to see him, which is not that easy to do. I don't know how many of you remember him, but he was quite wonderful. So she went to see him, and she's been on opioids for years. And I can tell you that she's been treated as an addict, even though she's not. She's been treated as an abuser, even though she's not. She's been stigmatized. No question about it. She went to see Moskowitz, and actually through a lot of different stuff, through neuroplasticity, she's been able to really decrease her dose of opioids. She's on practically nothing. But she also had to switch, because of an insurance thing, had to switch from one opioid that was working really well to another opioid, which didn't work quite so well. But this woman spends so much time taking care of herself and her pain. It's extraordinary. She still sees Moskowitz once a month, every couple of months, and it costs. It's about $300 a visit to see him, okay? She is in the pool every day. She does exercises every day. She's a Feldenkrais instructor and does Feldenkrais on herself, okay? So she works really, 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 really hard on taking care of her pain and is reasonably functional, but it's expensive and it takes time. She also is using medical marijuana. She lives in California. She doesn't smoke it. She has various tinctures, and she's got it down to a science. I tell you, it's amazing what goes on out there in terms of medical marijuana. If you have a good provider who really knows what they're doing with it, she has one thing that she takes in the morning that doesn't give her a buzz and allows her to function during the day, and she takes something else at night which makes her a little high and allows her to sleep. It's also allowed her to go down on her opioids. Montana Pain Initiative, we talked about that. I just can't congratulate people enough for continuing and doing things with it. The growth of palliative care has really been, I think, a great thing in our country, and I'm hoping throughout the state of Montana, we actually have a lot of palliative care programs here, and hopefully this fall are going to do our second annual Palliative Care Summit with my help from Kristen, wherever she went to. There she is. We had the first one 6 months ago, 8 months ago, and had Steve Panelet, who's a leader in palliative care across the country, come in and speak, and we had over 100 people there, and it was great. I don't have my head in the sand. I think there are two problems out there, one of which is the issue of overuse. But one of them is also the public health problem of pain in this country. I don't think either one of them have a quick fix. This is my favorite new quote. I will mention Bob Twillman in a minute, but he's the person who gave me this quote, and then I came across it in a book that I was reading. For every complex problem, there is a solution that is neat, simple, and wrong. So I want to spend a little time. I know you've heard a couple of times about the CDC guidelines. And I want to talk about it from the perspective of what American College of Physicians, thank you Pam Hebert for giving me this, has said about the guidelines. And I want to back up for a minute because years ago, there were guidelines that were sent out about who's eligible for hospice. And those guidelines then got adopted by CMS, and they really had nothing to do with who should really be appropriate for hospice. But CMS has now incorporated them and said, if these are the guidelines for who's ready for hospice and who isn't, okay? So I get a little nervous when I see guidelines and everybody says this is what we should be doing. I know there's some evidence-based stuff out there, but as a friend of mine has said to me, you know, it depends on which hip pocket I want to take my evidence-based stuff out of. Okay, so you can find it both ways. So the CDC report, and again from the American College of Physicians, the guidelines are a set of recommendations, not prescriptive standards and not rules. Okay? I think if we start using them as rules, we're going to miss out on a lot of things. We've got to recognize the uniqueness of each patient and be in line with efforts from other agencies to deal with abuse and addiction. We have heard a lot about addiction, and I think it's really key and really important. We don't have the services. I think President Obama, when he talked about the opioid crisis, was really clear that it's not just about opioids, it's about having the right services for abuse and addiction, and that without that, we can't do it. We've got to avoid language that is proscriptive rather than instructive and a guideline. Recognize that there's substantial problems with access to appropriate services for patients with pain. I'll talk about that in a minute. And this includes payment services for alternative treatments, payment for routine urine screening. I know that that's a great guideline in many settings and many patients, but you got to be able to pay for it. Access to addiction therapy, and we already heard about access to Suboxone. There's a risk of inappropriately labeling patients. I'm very, very hesitant to put on a patient's list, problem list, that they're a chronic pain patient. I may try to coach it as a persistent pain patient, but these patients are so easily labeled. I think there's a real chilling effect out there, and we've talked about that. We've heard about that. I'm not going to go through that again. But it takes time and training that's not easily accessible, and it doesn't emphasize what not to do. The training that doesn't emphasize what not to do, but what to do, and how to really take care of these patients who are really in distress. We need to know how to use our EMR and how to use our medical home. Surgeons, oh my goodness, surgeons. I just have to tell one quick anecdote about surgeons. Are there any surgeons in the room? Okay, so the one, here's an education issue. I have had two instances where my husband had surgery. One was a nasal polyp or something, I don't even remember what it was. He went home with 70 Percocet. And I called the pharmacy the next day. I said, this must be a mistake. I said, you made a mistake. You gave me 70 Percocet. He said, oh no, that's what this doc always does. Okay. Second time, my husband was in the hospital for back surgery, and he doesn't tolerate opioids very well at all, shall I say. And so he was off all opioids after the surgery, and I said to the surgeon, he said, okay, these are the meds I'm sending you home on, blah, 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 blah. And I said, we don't need any oxycodone. We don't need any oxycodone. It's okay. We're good. Sure enough, one of the prescriptions I was handed was for 40 oxycodone. I got you. Okay, so let me just give you a couple of quick things. This is a 49-year-old male with intractable pain in his leg. Community clinic refused to give him any opioids because it was suggested by one of their staff that he come see me. CHP wanted to see him but would not treat his pain. And this guy had Hep C. He had been in the hospital in a coma for a month. He lived with his history. With his mother. He had no addiction history. He was not employed. He was going to physical therapy, but they weren't aware because he was afraid to tell him that actually the physical therapist was causing him pain. So I had to talk to her. I switched him to a long-acting, but it took most of an hour and probably 45 minutes of time from my nurses and the patient care tech to get approval because this guy was on Medicaid, for him to get a prescription for an appropriate med. Okay. That's not good care as far as I'm concerned. There's another patient who I call these people pain refugees. I forget who coined this, so this was a 69-year-old female. She lives 50 miles from Bozeman. She only wanted to get out of her house to see her grandchildren. She's, and she could not get to see a physical therapist because of where she was living. I want to quickly end with SPAN, the State Pain Policy Action Network. How many of you remember Bob Twillman? He used to come to our pain initiative conferences. He's in Kansas. He is a public policy person, and he's actually this wonderful speaker. So he has created the State Pain Policy Action Network, which follows any legislative stuff that's out there about pain. Okay? In 2015, there were over 1,300 bills were introduced and tracked that had to deal with opioid prescribing. 1,300. 255 of them were signed into law. Okay? And so I listed their priorities there, but I want to show you one example of these laws. This is in North Carolina. The Board of Medical Examiners required any prescribing of opioids required that you see the patient initially and with any change in prescription. On the face of it, that makes sense, but then you have to look at issues around access, and there's no exemption for hospice. So as a hospice provider, I get calls all the time. Could we change this dose of this patient? Okay? And over the phone, I say, yep, let's do that. Okay? This is a hospice doc who brought this to my attention, who said, how am I supposed to, with the 5 or 6 calls that I get every day, see all these patients if I need to change their pain medicines? Doesn't work. Again, H.L. Mencken. And then finally, Prince. This is another big one that's now got everybody up in arms about what's going on. But my question is, first of all, one of the bills that's coming out is, let's make fentanyl illegal. Okay, great solution. Let's put everybody in prison who has a little bit of fentanyl. That's truly one of the laws. I forget which state it's coming from. But I really wonder about where was his community in all of this? How are we allowing these people, these very, very prominent people, who clearly have resources, and these are people who have resources, and we're not taking seriously their issues with pain, addiction, abuse. It makes me very sad. We need to do better in our treatment of not just seriously ill patients, but of all patients who require complex pain management, and we need to do much better at educating our healthcare team. And I think I made it under the 2 minutes. Questions? I know some of this you've already heard before, but I'm happy to entertain any questions.
You've brought up the point of the not enough services with a lot of different providers and the time not really, the math doesn't work out.
Right.
And in primary care, there's also the same studies just showing actually, I think it was the American Journal of Public Health, but if we just did the A and B recommendations of the U.S. Preventive Task Force, that was 7.6 hours a day.
Right.
And then chronic disease run out. How do we develop a system for a lot of these things? The doctor can, or healthcare provider should be involved, but how do we use our ancillary services or other ways to decrease all the burden on one individual and yet be able to take in the patient's concerns so that they're getting the right assessment and follow-up? And I'm not even talking about just the referrals, because I think in the referrals a lot of things get dropped too, and sadly in Montana some of the referrals are just not not available. But just even within your own practice, what are ways that we can change systems to?
So, did everybody hear the question? And I am concerned about that, and I'm not sure I have a good system. In my own practice, I have myself and another physician assistant and 3 incredible nurses. If I didn't have my nurses helping me, if I didn't have my patient care tech, I couldn't do it. But the nurses, I can tell you, they have so many tasks that they have to do to meet medical home, to meet, the various things that they have to put in, that I don't know. I don't know. All I know is that I focus in on my patients, not with not so much prevention, but who are you and what can I do for you and what are your needs? And if I start there, then the rest of it follows. But I don't have a good system. Thank you, guys. It was my pleasure.
Catherine, before you go, I had one question for you. And it has to do with the new CDC guidelines. When you look at them, it says, it's in regard to the morphine equivalent dosage. But when you look at it, those don't apply with people who have active cancer pain, acute surgical pain or ongoing pain. It also talks about palliative care in there. And my question is how many people may we have mislabeled as patients with chronic pain that really should be labeled maybe along the lines of patients who need palliative care? And what I'm thinking of is patients who've gone through multiple surgeries, multiple interventions, and they're just finished. They're done. How much would they do better in a palliative care situation as continuing in the chronic pain pathway?
So those of us who do palliative care are very nervous about getting a lot of chronic pain patients because we would fill up our practice. So we are very careful about, do they really have a serious illness, and do they need to have that conversation about what their goals are? And that we can help with. And we can help with some pain management, but a lot of times I'll make recommendations and send them back. But it's that conversation that I think people, we need to get more skilled at, and that is what we as palliative care physicians can do, is really help. What are your goals? Where are we heading? What are we doing?
Well, I'm thinking that as an option that, when we have these patients, maybe getting a palliative care consult, have some guidance on what might be appropriate measures, and then it kind of takes us out of that realm of this morphine equivalent dosages that we're kind of
Yes,
monitoring.
and I think that getting a palliative care consult is totally appropriate, and we certainly see enough of those patients. It's just we can't get overloaded with a lot of the persistent pain patients because we've got all this other stuff to do.
Well, it goes to my hopeful mission that I hopefully can inspire someone that I think more primary care should be managing a lot of these things in their
Absolutely. So big primary care education issue, not only about pain, but about what is palliative care and how to have those conversations and be comfortable with them. I don't think we're comfortable with either conversation.
Thank you.
Thanks, Mark.
I think we should give Catherine another big applause. I think she did a wonderful job. We appreciate her driving very fast from Bozeman for this, so